Thank you, and good morning, everybody. So my task for the next 15 minutes is to give an overview on diagnosis of gastroesophageal reflux disease, and I'll spend a few slides also on treatment, which is pretty straightforward. So just to inform as to where is Kansas City, it's right there in the center of the United States, and coming to Athens, Greece, it's my pleasure. We've had a wonderful few days here and are spending another week here in your beautiful country, so thank you for that. When we look at gastroesophageal reflux disease, there are multiple ways that this disease can present. First and foremost are the typical symptoms, and these typical symptoms comprise of heartburn and regurgitation. So if there are two symptoms which are cardinal for gastroesophageal reflux disease, these are the two symptoms. That you do not have gastroesophageal reflux disease. There are a lot of atypical presentations as well, or symptoms not typical of just esophageal symptoms, and these are listed here. Anywhere from non-cardiac chest pain, so chest pain in which cardiac workup is negative, to asthma or difficulty breathing, wheezing, which can be related to reflux disease. And finally, a number of complications such as esophageal strictures, we heard about that, and then of course Barrett's esophagus and esophageal adenocarcinoma. So what's the modern definition of gastroesophageal reflux disease? And this comes from the Montreal definition or classification of gastroesophageal reflux disease. If you look at the definition, it says that it's a condition which develops when reflux of gastric contents causes troublesome symptoms or complications. So again, the key point here is symptoms. So it's a symptom-driven disease, and troublesome, meaning that when an individual starts complaining and goes to the GP or to the gastroenterologist and complains about these symptoms, that's when it becomes a disease from just a symptom that you may be getting on an intermittent basis. The Montreal definition finally also breaks this down into esophageal syndrome, so these are the more typical symptoms that I just discussed, and extraesophageal syndromes. A number of these are well established, and they're listed such as the cough, laryngitis, asthma. These are well established relationships between reflux disease and these extraesophageal syndromes, whereas on the right are those which are proposed or suspected, such as sinusitis or pulmonary fibrosis, and we don't have good evidence that these are directly related to gastroesophageal reflux disease, but are some of these proposed associations, and a number of case reports have actually confirmed that this can happen. So again, so this is our current definition and understanding of gastroesophageal reflux disease. Now, what's the prevalence, and is the prevalence increasing? And these are data from the US looking at the population prevalence of gastroesophageal reflux disease. You can see that the prevalence varies anywhere from about 10 to 20%, and if you look at now close to 2005, 2010, the prevalence of gastroesophageal reflux disease does appear to be increasing, and I think this is true even from Europe and Asian data, in which the prevalence, at least in Asia, may not be this high, but still it's approaching the Western standards in which the prevalence of this disease is increasing. So what are the causes, of increasing gastroesophageal reflux disease? And a number of these causes are listed here, and in the US, we obviously want to blame our leaders for everything, so some of them propose that even Barack Obama is related to this, causing some heartburn because of the bad economy and stuff. But I think two important things which are listed here are the obesity and the decreasing H. pylori rates. So from epidemiologic data, it's clear that over time, this is esophagitis is increasing, and duodenal ulcer disease is decreasing. And these are again data from a large veterans database published several years ago now, but it's still true, which shows that peptic ulcer disease is decreasing in incidence, and during the same time, esophagitis has been increasing. So it makes a little bit of sense that maybe these different diseases may have a common link, and the common link may be Helicobacter pylori infection, and we will discuss that, but it's clear that this trend is happening, and if you look back in your practices also, you will have to think hard when you first saw or last saw a patient with gastric ulcer or duodenal ulcer. Most of them that you've probably seen are related to non-steroidal use rather than H. pylori. And these are data from Asia which sort of confirm that. This is what's happening to duodenal ulcer disease, and this is esophagitis. Again, very similar trends as in the US. And if you were to look at the H. pylori prevalence in Asia, you can see that back in the 1990s, these are data from Singapore, 50% of the population in Singapore had H. pylori as compared to the late 2000s, in which less than 30% of the population now has Helicobacter pylori infection. So there does appear to be an epidemiologic trend in which there is decreasing H. pylori infection and there is increasing gastroesophageal reflux disease. The second important issue is obesity, and I think that also is a global problem. I've listed Greece here, but I think if you were to pay attention to the rest of the map of the world, it also shows us that quite a significant proportion of the population is now obese, and obesity is not just now a problem of the Western world. Even in developing countries, though children may be malnourished, some of them are still obese, and so it's an important issue which may be contributing to this. One important thing for obesity is the size of the foods that we eat, okay? So here are some pictures on the left of the foods back from the 1950s. If you look at the size, if you were to go to Burger King at that time, that's your burger that you would get. McDonald's fries are listed there. And of course, the small Hershey's bar is there, which you can barely see. And now if you go through McDonald's, the first question they ask you is that, do you want to supersize it? Okay, so that's the first question. And these are the sizes now that you get there. So our proportion of sizes that we eat has significantly increased over the last 3 or 4 decades, and I think that does dramatically account for the obesity that we see all around the world, is the proportion of sizes that we eat. How does this impact the pathogenesis? Well, one of the major determinants of gastroesophageal reflux disease is the lower esophageal sphincter, which is mentioned right here. The GE junction compliance or the competence is dependent on the LES and the diaphragm. And obesity can impact both by disrupting the anatomy of the gastroesophageal junction, can cause hiatus hernias, can promote more gastroesophageal reflux disease. So there is a direct link. A number of other mechanisms are mentioned here, which you should remember, most importantly in your diabetic patients, which is gastric emptying. Those patients may have delayed gastric emptying, and unless you address that issue, their symptoms of gastroesophageal reflux disease may be persistent. So remembering a little bit about the pathogenesis may help you in your difficult to treat patients with gastroesophageal reflux disease. Now, as gastroenterologists, our focus remains on endoscopy. And if you look endoscopically, here are the different features if you refer your patient to your gastroenterologist that they may report in the endoscopy note. Most importantly and most common will be that your endoscopist will say the endoscopy was normal. It was non-erosive reflux disease, or no erosions were seen, or no esophagitis was seen. If you see that report, you should not think that the patient does not have gastroesophageal reflux disease, because again, the important thing is it's a symptom-driven disease. all it means is that the patient does not have mucosal breaks or erosions, which are seen right here, or erosive disease, or if they have a complication such as Barrett's esophagus. So again, the majority will have this. And what proportion will have a normal endoscopy? It ranges anywhere from 60 to 70%. And as more and more PPIs are used, that proportion keeps on increasing because the PPIs will heal the esophagitis, and what you will see is a normal esophagus. Esophagitis is decreasing, and about less than a third of your patients will have endoscopically abnormal esophagus with esophagitis, and anywhere from 5 to 10% of your patients will have Barrett's esophagus. So those are important numbers that you should know because that's your pretest probability of your patient being referred for endoscopy with symptoms of gastroesophageal reflux disease. Now, the other thing to remember is that the gastroenterologist will probably grade the esophagitis based on the LA classification or the Los Angeles classification. And what this means is how severe is the reflux disease from A through D. A is in which they will see just one small erosion. B is in which the longitudinal length of the erosion increases. And C's and D's are where there is more significant esophagitis with either mucosal breaks going over folds or 75% or 50% of the circumference of the esophagus being involved with erosive esophagitis. Now you may ask, what's your importance of knowing this? Well, the more severe the esophagitis, the more difficult it is to heal it. So for example, in grade C and grade D esophagitis, only 50% of them may heal with acid suppressive therapy or proton pump inhibitor therapy in standard doses. So you may have to increase the dose or give them for a longer duration of therapy. So just remember the Los Angeles classification, A through D, in which C and D represent higher grades of erosive esophagitis. And again, these are endoscopic photos. This is grade A, this is grade B. Grade C, you can see it's going over two mucosal folds, and grade D, in which there is involvement of 75% or so of the circumference of the esophageal mucosa. So this is endoscopic erosive esophagitis. So is there a gold standard for reflux disease? Endoscopy, esophagram or barium studies, or by doing pH monitoring? So 1, 2, and 3, what do you think? How do you make the diagnosis? What's the gold standard? Number 1, endoscopy. Okay, a few hands. Number 2, radiology. Okay, no radiologists. Good. Number 3, pH monitoring. So the rest thing, it's pH monitoring. So the real answer is that none of these are true because it's a symptom, again, driven disease. So there is really no gold standard for gastroesophageal reflux disease. And going back to symptoms, if your patient has typical symptoms, the likelihood of having reflux is more than 75%. So you really don't need a test to tell you whether your patient has GERD or not. It is based on typical symptoms. Since it's symptoms, you can sometimes have them fill out a questionnaire. And the reason I say this is that while patients are waiting in the waiting room, you can take some of these simple questionnaires, and I'm just giving an example of the RDQ, which is the reflux disease questionnaire. This is a well-validated, self-administered questionnaire which goes over 3 scales and 12 items. And these are listed right here. And the patient ranks them from 0 to 5, depending as to how frequent and how severe they are. So this may be a good tool that you can have in your waiting rooms. So before the patient comes and sees you, if they have these symptoms, they can mark them, bring them when they see you in your office, and you can actually have the diagnosis or calculate their score of GERD even before you start taking a history and a physical examination on your patient. So again, a simple tool that you can use in practices. The other thing to remember is that as our population is aging, as the esophagitis happens, it's inversely related to the age. So you may see a patient who is 70 years old with mild symptoms, but they may have more severe disease on endoscopy. So there's an inverse relationship. So always remember that, because sometimes your elderly patients may have mild symptoms, and don't ignore it because they may have more severe disease. The symptom perception reduces, and even though they may have more damage to their esophagus, their symptoms may be much lower. So again, a clue for you when you obtain histories from your patients. So you can actually use the PPI test or acid suppression test to make a diagnosis. Patient has typical symptoms, you give them acid suppressive therapy, symptoms go away or improve significantly, your diagnosis is made. You don't need an endoscopy, you don't need pH monitoring to make the diagnosis. Finally, esophagitis or reflux, how do you treat that? And that's with proton pump inhibitor therapy, and there are multiple analyses or meta-analysis which have shown that. This is placebo. You improve by giving them H2 blockers over placebo. And finally, you do best with more profound acid suppression, which is with proton pump inhibitor therapy. The important thing to remember is that this is a chronic disease. What percentage of the patient with relapse if you discontinue the therapy? And the answer is the highest percentage. In this, it's more than 40%. And this is from these data like this, is that if you stop therapy by 6 months, virtually all your patients, literally not all, but 80% to 70% of your patients will have relapse of their disease. So this is pretty much long-term therapy. You cannot treat them only for a month or two, and then if you stop it, you should be concerned that the disease may come back and their symptoms will relapse. So just remember that, okay? Finally, some of our patients may not respond appropriately. And here are some causes which are listed there. First and foremost is compliance. For these medications to work best, they should be taken before a meal and not after a meal. So if your patients are not taking it before a meal, they will not do well with therapy. Improper dosing and timing. These need to be taken every day. So if your patient's not taking it every day, they may not respond well to it. And then there are a number of these other listed conditions which you should be thinking of in your differential diagnosis if your patient with GERD does not respond to therapy adequately. And finally, just remember differences between typical GERD and atypical GERD. Symptoms are different between these conditions. The pathophysiology is a little different in atypical GERD. It's more multifactorial. Endoscopy findings are also uncommon in atypical GERD. And more importantly, treatment response is poor in atypical GERD, such as asthma, hoarseness of your voice, and things like that. And this is just some clues as to if you have a patient with wheezing or hoarseness of voice, when should you suspect reflux disease? Adult onset symptoms. So if they don't have childhood asthma, it's less likely to be your typical asthma, but GERD may be contributing. If they have nighttime wheezing, that's more likely to be exacerbated by acid reflux. And if it changes with posture, that's also related to it. And these are just some suggested algorithms of how to treat these patients with extraesophageal GERD. Is you give them a trial of therapy for 1 to 2 months, no longer than that. In the past, we used to say for 3 to 6 months, but now we have pushed it back and say give it a short duration of twice daily therapy for 1 to 2 months. If they don't respond, these are the patients who may need pH monitoring with extraesophageal reflux disease. If the symptoms persist and the pH monitoring is negative, think about other diagnoses such as smoking, typical asthma, some other causes, drugs causing cough, etc., rather than persisting with gastroesophageal reflux disease. And finally, if symptoms improve, what you should do is now titrate back And in all your GERD patients, put them on the smallest dose of medications which keeps their symptoms in remission. So I'll stop there. And Chairman, again, thank you for that nice introduction, and thank you all for your attention. Thank you.